Okay, so let's get this review started. So for the midterm, let me just go over again the outline that I gave you guys before, okay, but I just want to confirm a few things. So for the midterm, it will be a minimum of 50 questions, okay? Again, I will try to make maybe more than 50 questions, but the max will be 60. Okay, I'm gonna try not to go over that. So somewhere between 50 and 60 questions. Again, those questions will be split up to where we'll have definitely multiple choice questions, but we will have some questions that are the multiple answer type questions, which are the incline style. Labs and picks. You are responsible for the labs that we went over throughout the term so far. So just to confirm, there were different parts of the CBC that I had you guys highlight. And does anyone have their lab sheet? If you don't mind, I just want to clarify and make sure we're all on the same page with the levels. Thank you. So for your CBC, you guys should have highlighted platelet count. And again, make sure you remember that you are not responsible for any panic values for any lab. So the platelet count whole blood, you're also responsible for red blood cell count whole blood, white blood cell count whole blood, and we have white blood cell differential. Okay, so that's the only thing you are responsible for under the CBC. The next lab value that we went over, turn the page 487 at the bottom, we added in this week arterial blood gas assessment. So under arterial blood gas assessment, you are responsible for carbon dioxide, oxygen saturation, and pH of whole blood. Then when you turn the page, the others panel that we added in was lipid panel. So for lipid panel, you are responsible for cholesterol, just a desirable amount, HDLs and LDLs, again, just a desirable amount, and triglycerides. Okay, and then the very last lab value that we included were cardiac markers. And so we have creatine kinase MB, and troponin. Okay, so those are the ones. And so again, just want to clarify all the labs. And so those are the labs that you need to know for the midterm, and those only. Now, as far as the pictures, week 1 we had pictures for definitely the cellular adaptations, and we also had pictures for the different types of necrosis and gangrene. Okay, and I think those are the only pictures for week 1. Okay. Week 2 we had pictures of all of the different blood slides, okay, for the leukemias. Okay, so we had all the different types of leukemias and those slides for those. And then did I include the bleeding? I can't remember.
Yes.
Okay.
But you were summarizing that?
Yes, okay. So there is also with that week 2 pictures, we also had the last 2 pages of those pictures, I believe, were the bleeding disorders on the skin. So the petechia, purpura, the hematoma, those conditions.
Yeah.
Those pictures are also part of your midterm, so you're also responsible for that. Okay. And we didn't really get into that till week 3. And last week, I was in here, and so today, or this week, I should say, week 4, no, week 5, excuse me. Week 5, I gave you guys today pictures for chapter 23. So those pictures are pictures for some of the respiratory disorders, for restrictive pulmonary disorders. I will go over those when I do the lecture on that, okay? So which is part of this video, but I'm going to include that. So you're also responsible for those pictures for the, is it blinking? Mm-hmm. Okay, good. You are also responsible for those pictures for the midterm. Okay, so I just want to make sure. So, and we'll go over those in detail, but you're responsible for all those pictures. Okay, so that's that. So we got our labs and our pictures under control. Now, throughout the term, I did direct you guys to some tables in the book, okay, that I needed you to memorize for the test, and so we're going to also stick to those same tables. So for Chapter 7, you were responsible for looking at Table 7-1, 7-2, and 7-6. For Chapter 10, the only thing we did was Table 10-2, okay, and then 16, Table 16-2, if you remember, that was just a blood pressure classification, okay, chart. And then this week, we also added in for shock, for chapter 20, box 20-1, which went over the different categories of shock. And then the chapters are here. Okay, so again, chapter 1, 2, 4, 7, chapter 10, which was only table 10-2, and then 11, 14, 15, 16, 18, 19, 20, and then 22 and 23. I know that seems like a lot, but honestly, it was supposed to be.
And chapter 15 is the pamphlets that we.
Yes, okay, thank you. So chapter 15, remember, that was not an exact lecture, but we did cover that material in the in-class activity with those brochures. And so keep in mind that there was only 5 topics that I was wholly responsible for, which were DVT, varicose veins, for chapter 15. So DVT, varicose veins, Berger's disease, Raynaud's, and then aneurysms. Okay, so those are the only ones that we were responsible for.
And that was for 15? So
15.
it's the pamphlets, right?
Yes, 15.
5.
So, yes, there's 5. DVT, varicose veins, Berger's, Raynaud's, and aneurysms. Now, in some sections, the aneurysms were split up into cerebral and abdominal, okay? But it's just aneurysms, so make sure you just look at aneurysms in general. So, cerebral and abdominal aortic aneurysms, those are just the 2 most common types. So some of the classes where we had, more than 20 people, I had them split it up. All right, so let's get started with, you know what I did, I kind of know it off the top of my head. When I went to New Jersey, I took all my papers with me because I wasn't sure what was going on and when I was coming back. And so I had already set up with the IT person in case I had to do the class virtual. So I had brought all my stuff with me, so I think one of my PowerPoints got lost in there. Okay, but it's okay. No, it's
I have
okay.
it.
Oh, you have it? Okay.
Yeah, I have it rewritten.
Okay, thank you. Okay, so for chapter 1, so this review, again, what I want to do with this midterm review is just kind of go chapter by chapter and just try to give you a little bit of a focus, okay, with the material and, just how you should kind of proceed with your study guides and things like that. Okay, so for chapter 1, this chapter, pretty easy. The only thing we really focused on was definitely a lot of terminology, okay? So just kind of introducing the terminology for patho. I would say please make sure you know the terms, okay, like we did with that test, and make sure you also know examples. So I did give you guys examples in class, but I would say please also make sure you know examples that, kind of make up your own examples too, okay, just to kind of get familiar with it. Because the test question may not be my exact example. Okay. And that was basically it. There's nothing really I can say, oh, just focus on that, because I really do need you to know all the terms that we covered. The only thing, well, you guys know, we omitted those slides that went over like the epidemiology things. As far as like the statistics and the curve, bell curve and stuff like that, so we don't need to know that. But all of the other terms, yes. Okay, so all of those terms, yes. Make sure you know all the terms and examples. Okay, thank you so much. Okay, so for chapter 2, if you remember, this chapter went over homeostasis. Okay, and so this information should be somewhat familiar from a previous course. And so what we want to focus on here is definitely, number 1, knowing the definition of homeostasis, as well as knowing the definition of allostasis. Okay, so definitely knowing those definitions. Okay, homeostasis and allostasis. And, how can I say? knowing the definition, but when you write in your notes too, in your study guides, try to at least give an example of each one. Okay, because I'm really big on when you write, make your study guides, or even not just make your study guides. So usually what students do as far as, I think this is a good method to study. You write your outline, memorize, okay, which is what we do, we memorize the information. But not only just memorize, but make sure you understand, especially when it's like a long pathogenesis or something. But what you should always do, once you finish studying everything and you feel like, okay, well, I know the material, I got it, please make sure you test yourself. You need to do as many practice questions as you can. That's why I give you guys the practice case studies and, things when you come to tutoring. Okay, so that's what I utilize that information for people that do come out to tutoring and want the extra help. I do have papers, okay, that I give you for practice case studies and questions. So you can utilize that as kind of like your practice test at home, okay, just to practice yourself. Another good way to practice, and they have the test on Blackboard and things like that, and you can look at any book and use some questions. But another good way to practice is you take out a blank piece of paper and just kind of write out a case study. So say for example, if you want to write out a case study on asthma, okay? So if you just imagine and just say, okay, well, John Doe walked into Loma Linda emergency room and this would happen, he had chest tightness and inability to breathe, and just go through the whole thing. And if you write a case study from the top of your head, what it does, it forces you to pull out all of the information that you just retained. And what you can do when you finish writing your case study, you can look at that information, look at your notes, and see what you missed, okay? You always want to test yourself before you get to a graded test, because that way if you're strong, or I should say weak in one area, you have now time to go back and reinforce the information. And so that's a good way to do it. So saying all that, when you use, say for example, homeostasis, allostasis as that's a definition that you need to memorize for that term, when you write your notes for that, because it's just terminology, you can give yourself a little example after that material. Okay, so if you write the definition out, just give an example on the side, just so you can get an understanding. Why? Because your test questions are examples. Okay, so a lot of the test questions usually are not what is this, what is that, but just some kind of scenario, okay, that you have to figure out. So you want to include those examples with your notes. It's very important. Okay, now moving on with chapter 2. It went over different ways that the body handles stress. Okay, so a couple of things I want to point out here. Make sure you understand the flight or flight response is definitely part of that, okay? How the body adapts to stress. We also went over the different types of stressors, okay? So we know the different stressors. And not to go through each and every slide here, but I would say definitely when you go through this PowerPoint, make sure you pick out all of the hormones that are involved, okay? Because there's a number of hormones that are actually secreted during the stress response. So make sure you kind of highlight them and list them out, okay? Make sure you know all the hormones that are involved. And they have some more definitions in the last couple of slides about adaptation and coping and things like that. So make sure you go through those as well. So chapter 2, again, wasn't that heavy. A lot of it was, again, just terminology and knowing the definition of it, making sure you can give yourself an example. And again, I would say definitely focus on the hormones, okay, that are secreted, and know which hormones are secreted, okay, during the stress response. Okay, so that is chapter 2. So chapter 4. So chapter 4 went over cell injury, aging, and death. And there's really not anything I can pinpoint here. So basically, This chapter was divided into reversible cell injury and irreversible cell injury. So when you make your outline, I would definitely kind of separate it that way so you don't get the two confused. So under reversible cell injury, it just went into the different types like hydropic swelling and maybe some other ones. Like the fatty liver and the protein mutation and those things. And so you remember that slide where it shows you a couple of examples, different types. So that still falls under the category of reversible cell injury. So what I would tell you to do is when you're making your outline under reversible, just make sure you list the different types of reversible cell injury and then give, you know, the information on the side for each one. That information, I would imagine, would be more like a straightforward question because it's kind of hard to give an example with, okay, well, with fatty liver, it is what it is, it's fatty liver. So there's no example of that, but just knowing that, yes, it falls under the reversible. Okay, and so the fatty liver, yeah, let me just make that distinction now. The fatty liver, when we use that as an example of when we talked about that, that is an example of what we call an intracellular accumulation. So make sure you definitely go over that so we know intracellular accumulations when things accumulate inside the cell because of maybe faulty metabolism or whatever, okay?
What slide is that?
That is slide 5. Slide 5. It's the second page, slide 5. So it goes into intracellular accumulations. So 5 and 6. It's split up, so 5 and 6. So the point I'm trying to make is just know intracellular accumulations is still part of that reversible. Okay? Now, moving on, and this, let me make this distinction too. Moving on, the next sort of category was cellular adaptation. And so all of these cellular adaptations are reversible, excuse me, with the exception of dysplasia. Okay, so let me just confirm that. Yeah, dysplasia is irreversible. So all the cellular adaptations are reversible with the exception of dysplasia. Dysplasia is irreversible. And let me also make this clarification, because in your book they say that dysplasia is reversible, and so let me just make this distinction. The cellular change is irreversible. So once it goes into a dysplasia, the cells in the tissue, it's not going to turn back to normal. The only way to turn it back to normal is to remove it. But on the clinical aspect, can a person get out of a dysplasia? Yes. And they get out of it because of the procedure. Okay. So how it's treated is how it's removed. Okay. So in that sense, in a clinical aspect, it is reversible. But on a cellular aspect, it's irreversible. I hope I didn't just confuse you. Okay. So, and I just wanted to clarify that because, you know, when you do read the chapter, it just kind of focuses on the fact that, you know, it's reversible. It's reversible because it's treatable. Okay, it's treatable. Okay. Now, under the different cellular adaptations like atrophy, hypertrophy, hyperplasia, okay, so we know all that. Just again, same sort of thing, know what it is and know the examples. Okay, so we went over that in class. Also, yes, with the pictures. Yes, with the pictures. So also, you were given pictures for all the different cellular adaptations. So you can include that. So the next category was irreversible cell injury. And so for under irreversible cell injury, please make sure you know everything that has to deal with necrosis and gangrene. Okay, so obviously know the difference between the two. So again, just to confirm, the necrosis is how we explain what's happening at the tissue level, so the pathogenesis of what's occurring. The gangrene is pretty much like saying the diagnosis of the body part. So the foot is gangrenous or the toe is gangrenous. So what has now happened to the whole organ, okay, or that whole tissue area. So when you look at the pictures, and you were given pictures for necrosis and gangrene, when you look at the pictures, so not to be confused, because on a test question, you could have, because the pictures I have are different. I'm going to try to stick to the picture for what is titled. However, the wet gangrene, we know is liquefactive necrosis. Okay. The dry gangrene is coagulative necrosis. So just make sure you know which goes with which. Because you can have a picture of something that's a wet gangrene, and I can say, well, what type of necrosis is this? So, which is, it's a different title. It's the same thing going on, but one is just explaining the tissue, one is explaining the body part.
Can you tell us again what dry gangrene and wet gangrene?
Yes, so dry gangrene is a type of a type of coagulative necrosis. So dry gangrene is coagulative necrosis. So if we can maybe look at it this way, if we start the pathogenesis of it, the coagulative necrosis is going to occur first. If that continues, then that person is in a state of a dry gangrene. Okay. What will happen with liquefactive necrosis? Liquefactive necrosis leads to the wet gangrene. And I think those are the only two that were.
Yeah.
Gas gangrene.
Yeah. Gas gangrene, there's no necrosis that falls in line with that.
Well, it has a bacteria clostridium.
Yeah, that's from the bacterial, yes, from the bacterial infection. But it doesn't have an exact necrosis that it aligns with. So fat necrosis, they don't have an exact title for that type of gangrene. So fat necrosis is just fat necrosis, it just depends on where it's located. And then caseous necrosis is secondary to TB. And it's really just kind of localized just for TB to the lung. So caseous necrosis for TB in the lung. And so that's that. Is everyone okay with chapter 2? Okay. I'm sorry, chapter 4. So chapter 7. Okay, so this chapter has a little more information. So one thing with this chapter, make sure that you are able to distinguish the difference between benign and malignant tumors. So again, when you're making your study guides, if you just want to separate benign, malignant, and under that I would say definitely list all of the characteristics, like whether it's well defined and if it has blood vessels surrounding and is it mobile and all that I gave you in lecture. So just try to list all the different characteristics. It may be nice, if this will help you, to make a study guide where you can, under those two categories, maybe put the nomenclature, so the proper nomenclature for each one. So ulma is just for benign, and then we know the sarcoma and carcinoma is for the malignant. Okay, so you can separate it that way.
And that's the table that we have to
Yes.
table.
So when you, that's what I'm saying, when you make your study guides at home, make it where it's best for you to retain that information. So, you know, don't feel like, oh, it has to be this way or that way, like the book. Even some people that are visual learners, you can just pull out different pictures. Like, and it doesn't have to be pictures either of an organ, like you can have a picture of a balloon blown up. you know, to explain like what's going on with emphysema or something like that. Whatever's gonna help you to associate with that condition, okay? So you can make it however you like. And the next information goes over the risk factors of cancer. So then you would probably want to make another column or another list, kind of listing all the different risk factors of cancer, like the different foods, the smoking, obviously. What else did we talk about? HPV, and you know, so all of those you can just list all. And then I think we went into more detail with the types of foods.
Nutrition,
Yeah.
fiber, alcohol.
Okay, yes, alcohol, yes, alcohol, other factors and things like that. So you can just make a list adding all of that. We did go into a little more detail with tobacco use. So I would say yes, focus on tobacco use in the sense of knowing what types of cancers are associated with tobacco use. So we know that tobacco use is definitely going to give those carcinogens, okay, so we know that. But I would say to include knowing what types of cancers, okay, correlate with tobacco use. Because it's not always just, you know, lung cancer. Okay, so we did the nutrition. Okay, so then we went into the next category, which was metastasis. So for metastasis, just basically understanding what it is, okay, and knowing what happens when a person has metastasis. So we know that that cancer cell leaves the original tissue, where it came from, and goes either through the bloodstream or the lymphatic system, and then it spreads to a whole different site. So we know that's what happens with metastasis. And they give you the whole breakdown of the enzymes and all that. So just make sure you go into detail with that. The next thing with cancer and how, I should say when it spreads, make sure you know what happens with tumor markers, okay, so how they're actually identified. So we know table 7-6 is what I had you guys memorize. And so we're still going to stick to the same thing that we did for that test that week. And I'm going to have you guys just memorize the tumor markers just for the top 4 cancers, okay? So we'll stick to the same information. And so those tumor markers we know are secreted, okay, from the parent tissue, so where the cancer started. So even if a person has a cancer spread all over the body, they'll never be tricked as to figuring out what's the parent cancer. Okay, so that's the main thing with that. It went into angiogenesis. So we know that a lot of blood vessels surround malignant tumors, so we already know that. And the other item you should know definitely is the difference between grading and staging. The difference between grading and staging. Grading is really more so looking at the histology, okay, of the cell, whereas staging is looking at the patient, okay, so the patient as a whole. Is the tumor just localized? Has it spread? Okay, so what's going on? So grading is done in a lab with histology. Staging is looking at the person, looking at the patient as a whole. And then the next area went into the warning signs of cancer, and it gave you some mnemonics. Make sure you know those, okay, because like I told you guys before, I did see this, the mnemonic, the exact mnemonic in the NCLEX book as an NCLEX question. So they even asked, okay, what does caution stand for? Okay, so you'll be surprised if they may have that same exact question. So just make sure you memorize that for both adults and children. And then the last couple of slides went over complications of cancer, okay? So if you want to make, let's say, another category, okay, in your study guide, complications of cancer, okay, or signs and symptoms of cancer. So the pain, we know, we have a lot of things that come from the bone marrow suppression. So like these patients will have anemias, possible infections, and possible bleeding, okay, because of the decrease in those cells. And so you guys know that. And then the last couple of things with this PowerPoint went over the different treatments for cancer. Okay. So the main thing with emphasis on surgery, chemo, and radiation. Okay. And the other ones we know are not as what we call mainstream, okay, type of treatments for cancer. But sometimes when cancers are difficult, they may have to do something else. So chemotherapy, we know, kills the cells. Okay, it kills the rapidly dividing cells, and unfortunately, it can't just target the cancer itself. It kills all rapidly dividing cells. Radiation therapy is there to kill the blood vessels surrounding the tumor. So that's the philosophy behind that. It's to kill the blood vessels surrounding the tumor so we can shrink it. We're trying to decrease the size. And what was the other one? Surgery, yes, okay. Surgery, we know, to get it out. So that's that. Okay. So that was second. But I know what to do. Oh, now I find it. Okay, so for 10, it was only tabled 10-2. Okay, so you guys should have the sections already highlighted, okay, from that week that we had that test. And so it's the same information. Again, there's not going to be tons of questions from this, okay, because there's not a lot that we went over. So just again, making sure you know the 4 different types of hypersensitivities, and making sure you know those items I told you to highlight, okay, in particular. And again, one of the major things is making sure you know the examples, okay, because not only clinically do you need to know what disorders, but when I make your test questions, it'll be surrounded around that example. And that's basically it. There's not really much to say about that. Okay. So all of that is week 1. Okay. Now for week 2, did I have you guys, I can't remember, did I tell you guys to do, yes, you have a question.
Where in chapter 7 does it talk about the
Oh, okay, so let me explain, I had explained before. So for those of you who are new to tutoring, what happens is the papers that I have in the back actually come from a different textbook. So the chapters, I should say the numbers of the chapters are going to be off, but it's the same material. There, when you look at those questions on the quizzes, on the practice quizzes, and also on the case studies, sometimes it may have an item of something that we didn't go over. If you see something like that, you would just cross it out.
Okay.
But the papilloma is basically the long name for the pap smear. And so that particular question, I think, may be associated with a dysplasia. So just to let you know what that is.
Okay. Thank you.
The papilloma test is short for pap smear. And then, yeah, that's, what chapter is that for?
7.
Yeah, that's most likely for dysplasia.
Okay.
So that question's probably for
Okay.
dysplasia. Okay, so chapter 11, oh, that's what I wanted to say. Did I tell you guys to do lymphomas on your own?
No, we omitted lymphomas.
We omitted lymphomas. Okay, why did I feel like I told you to do it? Okay, that's all right.
Yeah.
It's okay, we omitted. Okay, so for chapter 11, you're only responsible, oh yes, I did, you're right, because I was going to put it on the list. Okay. So for chapter 11, you're only responsible for the leukemias. Okay, so let me just list the leukemias so we'll know exactly what you need to know. So for leukemias, we have CML, AML, ALL, CLL, hairy cell, and multiple myeloma. So those are the leukemias that you're responsible for. CML, AML, ALL, CLL, hairy cell, and multiple myeloma, also known as plasma cell myeloma. So there's two different names for it. Okay, so the best thing I can say, and I know it's a lot of information, is this. You are definitely going to have to make some sort of outline of this chapter to, and some of you were in tutoring before when I gave out the spreadsheet, okay? So a student a couple of terms ago had made a study guide, and so those of you who come to tutor, and I can give that to you when we're done, I can print it out. So you are going to have to use some kind of study guide to, just kind of have, say for example, the title of the leukemia, the picture that's associated with it, this is how you're going to have to break it up. There's common signs and symptoms that are for all leukemias, and then you need to divvy out maybe a symptom or a sign or even like a special testing or whatever, something that's a hallmark, something that stands out. And that's the key thing, because sometimes students get these questions a little confused or they think they're tricky because the signs and symptoms are pretty much the same, and so you really need to kind of clue in on that one thing that stands out. So when you write your study guide, just kind of put that one hallmark, put it in a different color, make it pop out, because when you read the test question, you need to, associate with that and just help you get to your answer. Obviously, the questions that have the pictures help you, okay, so then you know what it is, memorizing the picture. But if you don't have a question, if you have a question that doesn't have a picture, then you need to know all the information behind it. Okay? So with leukemias, you are responsible for obviously knowing what it is, knowing what cell it's attacking, knowing all the signs and symptoms, whether commonly shared or not, and signs and symptoms, and then the treatment. So the treatment, I'm going to try to stay away from treatment questions, okay? Number one, we do know that most treatments have to do with chemotherapy, okay? As well as sometimes, most of the times, bone marrow transplant, okay? So we do know that. I'm just trying to give you an overview of 11 because it is a lot of material and it's kind of hard to say, oh, just know this or just know that. To be honest, you do need to know everything. So that's why I said those 5, no, it was more than 5. How many leukemias? Was it 6? 6. So those 6 leukemias, make sure you know everything there is to know about those 6 leukemias, okay? And that was that. And we omitted the lymphomas, so you don't have to worry about that. Okay.
So just mainly focus on those, not like the treatment, the prevention.
Prevention?
I don't think there was.
Oh, that's for,
No, we don't have much prevention for it. Well,
it's for neoplasms.
Well, I'll say this, for leukemias, they do say that the risk factors for leukemias are when patients have like radiation, chemical exposure, and it was something else I forgot. I did my PowerPoint.
Like smoking.
Smoking is one, but they were saying that there are some definite risk factors. I know it's definitely radiation. Okay, so radiation exposure, because it attacks those rapidly dividing cells. Radiation, chemical, the viruses. Viruses. So make sure you know that those are definitely kind of special risk factors. So we know smoking is a risk factor for any kind of cancer, but those are kind of specialized risk factors just for leukemias. Those viruses, the radiation therapy, and the chemical exposure, or radiation and chemical exposure. So, again, there's not anything I would say pinpoint. Obviously, you really need to go through each and every slide in that chapter, okay? Even talking about the bone marrow transplant and knowing that a patient needs chemotherapy done first, okay, that's the protocol, they have to have that done first before the bone marrow transplant. So again, there's a number of things. I usually always ask a question, the difference between autologous and allogenic, okay, so knowing the different types of
So
transplant.
auto is coming from the patient itself, and then
Allogenic is when they get a donor. So knowing the difference between the two. So again, there's nothing I can really pinpoint, just kind of everything there. Okay, so. Why am I missing half of my PowerPoint? Because the rest of, this is like for the final. That's the second half of the course. Okay, thank you. Thank you. Oh, that's fine. Okay, so for 14, yes. 14 was the blood coagulation disorders. Okay, so with 14, what I had you guys do, and this is one of the PowerPoints that I tailored down just to the clinical information. So number one, this was the PowerPoint that has also pictures from that week of the bleeding on the skin. Okay, so the bleeding on the skin, those presentations, the petechia, purpura, hematoma, okay, those types of things, those correlate with this chapter, chapter 14. Now, again, it's hard for me to pinpoint. This chapter, although it seems like it had a lot of information, it's really not that detailed information. So when you make your outline for this chapter, it should be easy. All you have to do, number one, go over, maybe make a section for, let's say if you had a patient, let's say history and physical or assessment. So you would make a category for that. And list out all the things that you would say, maybe ask the patient about their history. Do they have a family history of bleeding? Do they have liver disease? Okay, things like that. So just kind of write out a different section for history and physical. Okay, so and then include all the things that we discussed with those slides. Okay, and that would even include blood testing. So they would have blood work done. Okay, looking for the red blood cell count and all that, platelet count. So you can include that in one section, you know, just a workup, whatever you would do. And then once you're done with that section for the workup, then you can make another kind of outline just going over the different disorders. So you can list the disorders. So this is what I need you to do, and this will be easier for you. All you have to do is just make sure you know the name of the disorder, know what the issue is, obviously what it's attacking. The signs and symptoms are very, I won't say difficult, but they all kind of are the same. They're bleeding, okay, obviously. But the signs and symptoms, some disorders have more distinct signs and symptoms or hallmark symptoms than others. So if one has more nosebleeds and one has more the telangiectasia or whatever, so just figure out, and I gave you that information in lecture, just figure out which one has like that common type of bleeding disorder, bleeding presentation. And then treatment for these conditions are very hard, so it's hard for you to kind of add in a treatment and memorize, okay, the treatment for this, you know, that situation. One thing you should know, and this just goes for anything, if a person, whatever is the issue, you want to treat that. Okay, so that's just kind of makes sense. So when you put in a treatment section, I don't want to say just, you know, omit it, don't put in treatment. But what I want you to do is for the treatment section, you can put in, okay, well say if they're lacking vitamin K, give them vitamin K. If the issue is,
Underlying cause.
yeah, whatever the underlying cause is. So whatever the underlying cause, that should be included in your treatment along with managing the blood loss. Okay, so along with managing the blood loss. And to be honest, I'm going to try to stay away from treatment with this because it all depends on the situation. So we don't want to just say, oh, that's the treatment for that and that's it. It just depends on the situation. However, I did have a question about treatment for hemophilia on the previous test, and because that one's easy. Okay, so, something like that, I could test you, have a question about treatment for that. Because the treatment for hemophilia is given the factor they're lacking, okay, or that frozen plasma. Okay, so that's easy enough. So, I wouldn't expect a whole bunch of questions from this, okay, to be honest, but it's there. Okay, thank you so much. Okay, and then 15, this was that week we did the assignment, okay, for the brochures, okay? So, as we said, there's different ways we can learn, so everything doesn't have to be a lecture slide by slide. And so what we did, we actually had an activity where you guys took one of those 5 disorders and actually made up a brochure with the different categories, okay? Etiology, risk factors, so forth. So again, just to confirm, and I know I said this earlier, but I'm saying it even for the camera, just to confirm the disorders that you're responsible for: DVT, varicose veins, Berger's disease, Raynaud syndrome, and aneurysms. Okay, and aneurysms. Raynaud syndrome and aneurysms. And so, just to also confirm, in some sections, aneurysms, when you guys did the activity, some people split it up into cerebral and abdominal aortic. When you look at that information, whether in your book or in the PowerPoint at home or the brochures, I need you to understand the physiology, obviously, of what an aneurysm is and what's going on. But just know that the cerebral and the abdominal aortic aneurysms, those are the 2 most common types. Okay, so it's just knowing that those are the 2 most common types. However, you should know just the basic information about aneurysm. Okay, and so the brochures had everything pretty much laid out with the different categories: etiology, risk factors, signs and symptoms, pathogenesis, treatment. That information is pretty much straightforward. I think a lot of us even know those conditions or heard of them, okay, because they are very common: DVT, varicose veins. Okay, so I think you'll be okay with that. So that's not a big to do. And if you have any particular questions on that, just let me know. If you feel like you're missing some information. Okay, so I think I should have 16. There's 14. Okay, everything's just all mixed together. I do have 14. Oh, thank you. Wake up. Okay. So for 16, I'm trying to think. Did I have you guys just start right at hypertension? Did your PowerPoint starts right at hypertension?
Alterations in blood pressure.
Alterations of blood pressure.
Arterial blood pressure.
Yeah, arterial blood pressure.
Okay, so I did go over. Can I see the PowerPoint for a second? I just want to make sure I have the right information. Oh, okay, so I did go over everything. Okay, good. Thank you. Okay, I just wanted to make sure you have what I had. Okay, so for chapter 16, this chapter talks about alterations of blood pressure. So this goes over, remember, the first half of this chapter went over just the normal physiology of blood pressure. And this is where we went into detail with what happens, short-term and long-term regulation. And remember, we also included some hypertensive medications, okay, with this, and going over and knowing, okay, which one goes under which category. So make sure you review that. I will most likely have a question from that, I can guarantee that. So make sure you go over the difference between long-term and short-term regulation of blood pressure, knowing the physiology of it. As well as knowing the what am I saying? My brain sometimes just stops.
Ours too.
The medications, I'm sorry, the medications. So knowing the physiology of the difference between short-term and long-term regulation and knowing the medications.
Beta
'Cause-
blockers.
yes, so we went over alpha blocker, beta blockers, okay, and that was for the short-term. And then the long-term regulation, we made another list, okay, and added some more to that, which were the ACE inhibitors and the vasodilators and all that, okay, diuretics. And so you guys have that list.
Yes.
So just make sure you know that information. Okay. Okay, so let me give you some other things that we don't want to miss, okay, with that first half, okay, before we get to hypertension. We went over the difference between indirect and direct measurement of blood pressure, so that's important to know. So there's two ways of measuring a blood pressure, so we don't want to forget that. And I think that was pretty much it. Okay. So now going into the actual condition hypertension. There's really nothing I can pinpoint. I would say please make sure you know everything about hypertension. Because why? Number one, you're gonna see it. Number two, you need to know everything about it. So the first thing is that blood pressure classification chart, which was table 16-2. Make sure you memorize that, okay, and know the classifications. And then hypertension was divided into primary and secondary, okay? Primary being the most common type of hypertension. And then secondary, we know secondary hypertension had to do with usually secondary to a primary condition. So whatever that may be. And
Are we gonna have to know the children one?
no. So you are not responsible for anything with children with the exception of ALL. Okay, just no ALL for children. We're gonna try to leave children out of it for right now because I do have to do a separate lecture on pediatric type disorders, and so we'll do that separately. I don't wanna intertwine it. But that's the only thing that I can think of. Yes, ALL, pretty much. And then for cancer, it's just kind of knowing the warning signs for cancer in children, but that's it. So we're gonna leave that out for children for blood pressure, and even when we talked about asthma, we don't have to worry about children for that, for right now. Okay, so the other thing I wanted to point out, and this is with primary hypertension. With primary hypertension, please make sure you know the end organ damage. That's the biggie, the end organ damage. And make sure you know which organs can be damaged. And I would even possibly go into, the physiology of what's happening, okay, like that flow chart.
So that was for primary?
Yes, that's what primary. It's under primary.
Inorgan damage.
However, secondary can have inorgan damage too, but they have it listed under primary.
Oh, yeah.
Okay. So we know when patients have hypertension, and we even know this just common knowledge, when people have hypertension, if it goes, how can I say, uncontrolled, they could have, leading to, headaches, okay, if they're having a, stroke or cerebral type situation. It can lead them to a possible aneurysm. It can cause them to have retinal issues with the eye. It can cause them to have kidney issues, okay? So just make sure you go over the different organs that can be affected, okay, because that's key. And the reason why that's key is because when you guys also do physical assessment later on, you'll be looking, okay, for signs and symptoms of those types of things, so you can see what type of damage occurred, okay?
Yeah.
And that's important. So it is important to look at the eyes and all of that. Okay, and we also went over lifestyle modifications with hypertension. So, I don't think I'm gonna have a bunch of numbers and values that you're gonna have to know for this. However, make sure you know what they need to modify. Okay, so if you have a patient, okay, that's hypertensive, and yes, they're given medication, but you definitely have to sit down and instruct them on making sure they decrease their salt, maybe lose some of the weight, okay, eat a little healthier. So just know those things, okay? And the last two things, we went over hypertensive emergencies and urgencies, so make sure you know the difference between those two. And basically, it's hypertension, but one causes immediate in-organ damage and one doesn't. Okay, so that's the only difference. And
Which one causes the organ damage?
The emergency.
emergency. Hypertensive emergency causes the immediate in-organ damage. The urgency is just hypertension without the in-organ damage. Oh, I have listed here, I don't think I gave this to you guys, but I have listed here that hypertensive emergencies and urgencies occurs more in males and higher incidence in elderly African Americans. Now, what's happening, when we talk about cardiovascular conditions, they do say that males are more at risk just in general, okay, for all cardiovascular conditions,
Because they
hypertension.
build their way up here.
Yes. And then the other thing too is African Americans are more at risk also for cardiovascular conditions. So hypertension, definitely hypertension and so many other things, okay? So that's just that category. Now, they say males are at higher risk, yes, because of their build. However, females are kind of catching up, okay, with having high numbers of hypertension and things like that. Because again, keep in mind a big lifestyle component to this. So the more we change our lifestyles, okay, with working a lot and whatever's going on, unfortunately, the more fast food people eat, you know, so that type of thing. So we know all that. Okay, and then the very last thing, low blood pressure. And with low blood pressure, there was only,
One.
yeah, they only have 1-2 slides on this. Low blood pressure has a lot to do with positioning, so that's kind of the key thing there. And they do have some possible causes of low blood pressure, and they're all listed there, so just kind of take a look at that. Sometimes it has to do with the medication a patient may be on, okay, or their environment. And the treatment is there, and the treatment is pretty much maybe altering the medication that they may be on, and basically just changing things in the lifestyle. Okay? Just changing things in the lifestyle. Okay, you guys okay? You need a break or you okay? Okay. So 18, okay, so 18, this chapter went into most of the cardiac disorders. Okay, so we went into detail with the cardiac disorders. I'm gonna try my best not to really divvy this up so much, but you honestly kind of need to know every slide. I'm sorry to say that. Yes, you do need to know every slide. There's really nothing I can kind of pinpoint. So let me just give you, you know, a little guideline here. So, number one, the first thing that was discussed was coronary artery disease. Okay, so that's definitely one disorder that you have to go into detail with. This is where we definitely added in that lipid panel, okay, to use for that. And understanding how atherosclerosis, when people do have atherosclerosis from the poor diet and all that, that can build up in the coronary artery and cause a whole bunch of issues. So once a person has coronary artery disease, I think the second kind of phase we went into was understanding the complications that can happen from that. So going into detail with the ischemia and going into detail with the types of angina that can occur. So we went over angina and we went over the difference between acute and acute and chronic coronary syndromes. Acute and chronic coronary syndromes. So when you write your outline for this chapter, you really are going to have to take it piece by piece. Okay, so each disorder separately. Although, if you look at it as a whole, sometimes they can intertwine, okay, some of the things. However, I just want you to take it piece by piece so there won't be any confusion. And then we went into detail with acute coronary syndrome. And that was where we were able to pull out the different types of MIs. Okay, and so remember, we went over it in detail with the chart, the STEMI and the non-STEMI, okay? So make sure you know all that information. That is important. And this is where we also added in for our lab values cardiac markers. Okay, so cardiac markers were added in for the MIs. Cardiac markers are used for MIs. Okay, and we talked about sudden cardiac death. And then after that, we went into each and every valvular disorder. Okay, that is most common. So for that, again, you may have to make your own separate little outline or guideline for that. I've seen students, they just kind of made a big heart, like on a poster board, and then just kind of really went through each chamber and kind of list which, you know, valvular disorder matches the chamber or whatever, and kind of did it that way. So however you need to do it, okay, to, you know, understand it. And I think it's a total of 6 valvular disorders.
5.
5, okay, 5. So that's 5. A total of 5 valvular disorders, and then we have a total of 2 infections of the heart. One is rheumatic and one is infective endocarditis. And, well, we can say 3. I just gave you really quickly what a myocarditis is. Most of the times it's just a viral cause, okay, for that infection. Not even sure if I'll have a question with it, but just so you'll know, because we didn't get a chance to get into that in detail. And that was basically it for 18. So again, I know it seemed like I kind of breezed through it, but it's very difficult for me to say, oh, you don't have to worry about that. You do need to know each and everything with cardiac. And cardiac is a big, big thing.
So the 2 infections were myocarditis and what else?
Well, I said 2, but it's really kind of 3. So myocarditis, rheumatic heart disease, and infective endocarditis. Infective endocarditis. Oh, we're almost done. So, let me put here. I have to keep up with all of this, just like you guys. Okay, so 19. 19, super easy. The only thing with 19 is understanding what is heart failure, obviously, and then going into the difference between right and left heart failures, okay, just knowing the difference between the two. So we went over that this week, and I think we have a good understanding of that. Okay. And that's basically it.
So
Was
mainly
everyone okay with heart failure?
focusing on the backward effects and the forward effects?
Yes, so everything with right-sided heart failure and everything with left-sided heart failure, understanding the physiology as to what's happening, as I explained in class. And also, the last little bit of information I gave you too was just knowing that patients sometimes can have both right and left-sided heart failures at the same time. And then we went over just some kind of diagnostic testing, okay, that can be done for that. And that's it. That's it for 19. 20. So for chapter 20, it's this shock. Shock. So for shock, again, I'm gonna need you to know that box 20-1, okay, so that's the first thing. Knowing that, knowing the different categories of shock and knowing what examples fall under which category. The second thing with shock you should focus on is the physiology, okay, or I should say the pathogenesis of shock. So the pathogenesis of shock. And the pathogenesis of shock covers what's happening at a cellular level, okay, or tissue level. And that's for any shock, no matter if it's anaphylactic or septic or whatever, what's happening at the cellular level. It's the same. And then we went into all the different types of shock, okay, so let me just list the shocks for you so you'll know which ones that we discussed. So we went over cardiogenic shock, and then we also went over, okay, thank you, obstructive shock, and then we went over hypovolemic shock. We also went over anaphylactic shock. Neurogenic shock, and septic shock.
And distributed.
Distributive is
Oh, yeah.
anaphylactic, septic, and what am I saying? Neurogenic. They fall under distributive. Okay. I just wanted to list out the exact shocks we focused on. So cardiogenic shock we focused on in detail. Obstructive shock we focused on in detail. We focused on hypovolemic, anaphylactic, neurogenic, and septic shock. Okay, so you are responsible for that, all that material, okay, that we discussed with those. And the last little bit of information for chapter 20 just covered the complications of shock. So that information, not that you have to get, too detailed with that, but just make sure you know that those 4 things are possible complications of shock. Meaning that those are the organs that are more vulnerable, okay, when a person has a complication of shock. The lung is vulnerable, the kidney, okay, the bleeding issue that can occur. So just know that those things, even the multi-organ failure, are things that can happen as a complication. And that was pretty much it. This is the last one, and then what's going to happen, I'm going to take a break, and then I'm going to do the lecture for 23. So, and if for those of you who can stay, if you can, it's okay. It'll be posted tomorrow morning. All right, so 22, this particular chapter went over obstructive pulmonary disorders, and we focused mainly on COPD type conditions. So let me just list the conditions that we covered. We covered asthma. We covered acute bronchitis. We covered chronic bronchitis. And we also covered emphysema. So that was a lot of information, as we talked about earlier. And so with this chapter, the reason why it's so long, okay, spread out to 70 slides, is because it really breaks down the pathogenesis in each and every little detail. Okay. So, like I told you guys earlier, when you make your study guide for this chapter, it'd be nice if you can, put the title, obviously, condition, etiology, risk factors, the section for that. When you get to the pathogenesis section, you may have to, kind of make your outline like tiered, okay, and just divvy it out and say, okay, well, this is what's happening at the epithelium, this is what's happening in the airway, what's causing the blockage. So you may have to just break it apart, okay, and organize it. The key thing to this material is organization. You really have to take time to organize it and pull it, okay, together. And then once you're done with the pathogenesis portion, just make sure you also know the signs and symptoms of these disorders, because that's important. These topics for 22, they also went into great detail with the different types of diagnostic testing. So I would even have that again as a separate section, diagnostic testing. So whether it's the skin testing or the ABGs, okay, whatever. And treatment, yes, okay, and treatment. And so treatment, again, it is important for you to know, yes, as I talked about, the treatment goal, okay, so you'll know what the goal is regardless of what you're going to give them. And then just knowing the exact treatments, okay, for each one. In the treatments, it should be easy to memorize because they're kind of the same, okay, for all of them, with the exception, I think, asthma has something a little different. But most of it is you give them oxygen, open up the airway, bronchodilator, okay, or corticosteroids, and decrease the inflammation. The only thing that's different is with chronic bronchitis and emphysema, you want to give them something to fight that infection because they'll have more upper respiratory infections, and give them cough suppressants because they have like excessive coughing. And I think that's it. It's a lot of material, but once you organize it, you'll be able to pull it together. So, any particular questions about any of the material that I just went over? So again, what I tried to do, instead of doing a whole lecture again for the first half of the course, just trying to give you guys each chapter piece by piece and just kind of a little focus, and just a little way to focus on it. But again, I can't stress enough, it is key if you can make sure that you do as many practice type questions as you can, okay? Wherever you get them from, okay, doesn't matter where you get them from. But try to do as many practice questions as you can. Okay, so let's take a break. Okay, so the midterm review is pretty much done, with the exception of 23. So what I'm going to do is we'll take a break now, and then I'm going to come back and do 23, okay, the lecture for that, so then we'll have a complete everything, okay, for the midterm.
It's not.
Okay, so we're back, and we are now going to cover chapter 23. So chapter 23, if you remember in lecture, we were able to cover this week 19, 20, 22, and 23 was also that chapter that was on your lesson plan. So we didn't have time in lecture, so we're doing this separate video for that. Okay, so for 23, this original chapter, again, just like 22, had like 160 slides or whatever, and so I did have to tailor down again some of this material. And so what I did, I tried to tailor down the material to where we're focusing on, I would say, maybe the most common type of restrictive pulmonary disorders. Although there are some other restrictive pulmonary disorders that I do have on your topic list for your presentations, so like TB, okay, and some other things, pneumonia that people will do, you know, for week 8, okay, so we will get some more education on it. So the first item that we have is sarcoidosis. So again, let me just get to that. I had to tailor down some of this information. Okay, sarcoidosis. Sarcoidosis, they have all of the information here as far as the incidence and things like that. However, just a few things I want to point out just to get to the point. Sarcoidosis is a condition where they do say it has an unknown cause. And the issue here is that the body will actually make macrophages that attacks the lung tissue. So there's macrophages that will attack the lung tissue. So when we talk about sarcoidosis, it's almost good to say that it's almost like an autoimmune type of disease, okay, where the body just kind of attacks itself and we don't know why. Okay, so it can be acute or chronic systemic disorder with an unknown cause. We don't know why it develops, but it just happens in these individuals. Sometimes immunological, so they do believe that sometimes the immune system is just set off, okay, for some reason. And when the immune system is set off, what will happen is it will now trigger the body to secrete a whole bunch of macrophages, and it'll attack the lung tissue. So it'll attack the alveoli in that situation. So the pathogenesis of what happens here is this, and I would also say, if you want to jot down, that this is the hallmark of the disease, okay? This is the hallmark. So these patients will have what is called development of multiple uniform non-caseating epithelioid granulomas. Okay, so I know that's a mouthful. So what that means is this. They will have multiple granulomas. So number one, let me give you the definition of a granuloma. A granuloma is a ball, or let's say a mass of immune cells. So a granuloma is a mass of immune cells. So it's a mass of immune cells. And epithelioid, meaning that it's epithelial type, in the epithelial tissue, I should say, in the epithelial tissue. And then non-caseating, meaning that, you know how we talked about caseous necrosis, okay, in chapter 4? And it kind of looked like that wet, cheesy liquid, I shouldn't say liquid, but kind of wet, squishy appearance. This, when we talk about caseating, is actually hard. Okay, so these are more solid granulomas, to be exact. They're more solid. So these granulomas are solid, they're in the epithelium, and the granuloma is just a ball of immune cells. So all the macrophages, they just come in the tissue, attack, and they actually just kind of ball up and make a ball in these different regions. Now, another key thing here, it doesn't only attack the lung tissue, okay, and this is kind of our first time seeing this with a respiratory condition. It actually can attack other organs. So I want you to know that it can attack the lymph nodes, the skin, the eyes, the spleen, the liver, the kidney, and the bone marrow. Okay, so you can just highlight that sentence. However, the lung is the most common type, but it can attack those other organs. Okay, so that's all we need to know. Now, this is just a diagram here explaining that, showing you that they do believe the immune system just gets set off. Okay, for some reason, an unknown trigger, you have no idea what happens. And it causes the lymphocytes, okay, these lymphocytes to just get activated to the point that now it makes activated macrophages. So when these lymphocytes get activated to make macrophages, the macrophages will actually go straight to the lung tissue and start damaging the lung tissue. Okay, and just pretty much attacking it. So that's that. Okay. So clinical manifestations here. Okay, so these patients will have malaise, fatigue, weight loss, fever, dyspnea, dry, non-productive cough. The cough is non-productive because they really do not produce a lot of mucus production in the airway, like when we talk about obstructive pulmonary disorders. So they really don't produce any mucus. Erythema nodosum, that's a term for painful skin lesions. Erythema nodosum, that's a term for painful skin lesions. And these patients, believe it or not, will have a considerable amount of skin lesions, okay? And again, unfortunately, it will attack the skin just as well as the lung and everywhere else. So macules and papules, did you guys go over macules and papules in micro? Okay, so a macule is what we call a flat lesion, whereas a papule is like a raised lesion. Yes. And so macules and papules are not just localized, to this. They do have them in other diseases. That's why I said micro, because I want to say in syphilis, they also develop macules and papules too. Okay, so macule and papules. Macule is a flat lesion. Papule is a raised lesion. Okay. Hyperpigmentation they can have also on the skin, and then subcutaneous nodules. Okay, so they could just have protrusions coming out of the skin, the tissue. Hepatomegaly, splenomegaly, lymphadenopathy, because again it's attacking those organs. So let me go to you guys have this picture? Because I can't remember if I put this picture.
Yes.
Okay, so this picture that you have on your image sheet, okay, that was given out in class, this image shows a very good example of a macule. Okay, and so that is a lesion of the skin. As you can see, it's definitely some destruction or inflammation that has occurred, causing that lesion, okay, that redness appearance, and it's flat. Okay, sometimes people can have lesions like this that are raised, okay, sticking out of the skin. These lesions, I want you to know, are painful. Okay, so when you look at that, it probably just looks like a rash or something. But this is painful. Okay, these patients do have pain with that. So for diagnosis, I'll just try to get through this quickly. The best thing I can say is just try to memorize this. And so the diagnostic testing that are done, when you look at some of these tests here, they basically correlate with the organ that's being affected. Okay, so if a patient has leukopenia, obviously the white blood cells, okay, count is low, anemia, red blood cell count is low. Increased calcium levels, for example, if they have increased calcium levels in the blood, that means most likely it's attacking the bone and breaking it down. So you get the picture, okay? So you can go through that. Another type of test that's done is Gallium 67 scan. And this is basically pretty much like a nuclear scan that's done. And what it does, it detects areas of diseased tissues in the body. Okay, so it's just kind of a general scan. I'm quite sure they inject some sort of dye. And it just kind of picks up that activity, or what we call like hot spots. So remember in week 1 where I was saying that disease has that oxidation reaction, okay, that occurs. So it actually picks up those reactions, okay, with the dye and what's administered. So you can pick up the area where destruction is occurring. PFTs, like we did with chapter 22, just leave it alone. We're not going to get into PFTs. And bronchoalveolar lavage. Okay, what is this? This is where a tube is placed down the airway, and what they can do is actually take a sample of fluid out, and they can look at that fluid and see what type of inflammatory changes, okay, has occurred. And another thing they can do is what is called the lung biopsy. Okay, so they can go in and do a biopsy of the lung, and they can look for what are those non-caseating granulomas. Okay, and they do say that's a definitive diagnosis. So let me just go back to the pictures because there's some more. So 2 more pictures I want to show you. So for sarcoidosis, I think your first picture that you have is this one with the chest x-ray, okay? So if you look at this chest x-ray for sarcoidosis, what you can see here is that you see the lung field. The lung field is going to show definitely that black region, okay, because of the density. It'll show it black on plain field x-ray. And in this region here, if you look at the lung, the midline of each lung should continue being clear or black. The problem here is that you see this hump here, you see that there, and that there a little bit. Those are the areas of the granulomas. Okay, so you can tell that the areas of the granulomas on a chest x-ray. And one thing I also want you to jot down is that these granulomas are actually located at the hilum of the lung. Okay? And if you remember from anatomy, the hilum is the midline. So the hilum of the lung or the midline of the lung. Okay, so this is where you're going to see these granulomas. Very rare that they'll be all the way out, okay, in the outer part of the lung field, but more so in the middle. Okay, so that's one picture. So we already went over the macule, so that's the presentation of the skin lesions that they'll have. And this particular picture is a picture of a specimen of obviously the entire lung. And so what's happening here with this one, you see this area here, which again is at the hilum of the lung, and you see those circles, okay? Those are the granulomas. And those granulomas, what you should know, again, they're non-caseating, which means that they're solid. They're actually very well defined, okay, and they're localized to that area. So it's almost like if you look at this, it almost looks like you could just kind of scoop it out or take it out because it's that well defined. Okay, so that's that. Oh. So when the chest x-ray is performed, this is when they start to stage, okay, the sarcoidosis. So sarcoidosis is staged, okay, and depending on how much damage or how extensive it gets into the lung field. I'm not going to test you on the staging. Did I give you that in the PowerPoint?
Yes.
Okay. So it's in your PowerPoint, but you don't have to worry. I'm not going to get into detail with the staging, but just know that the staging occurs when they do the chest x-ray. Okay. So we'll just leave that alone. And then treatment for sarcoidosis, the only thing that can be given, honestly, is something just to manage these patients for that moment. Because we do not have a known cause, there's no particular treatment to cure it. Corticosteroids will help kind of relax the airway and just kind of help, even with their pain that they're having and those inflammatory buildups, okay, on the skin. And immunosuppressive agents. So that can be given to try to maybe control the macrophages, okay, to kind of stop this activity. And that's that. Okay, what's your next one?
Acute adult respiratory distress. So there's no treatment for sarcoidosis?
No, there's no cure. No cure. There's treatment, and the treatment is really just to manage them and try to get it under control. Again, with the corticosteroids to kind of relax and get some of that pain and inflammation down. And the immunosuppressive agents help decrease some of those macrophages, hopefully, to control that response. Okay, now, we do have acute or an adult respiratory distress syndrome. We were introduced to this when we went over the chapter with shock, if you remember. And so one thing you should know is that, again, a respiratory distress syndrome usually develops from some sort of primary condition, okay? It is quite common that patients can go into a respiratory distress, okay? So they give you the amount of cases here per year. You don't have to memorize all that, but no, it is quite common. So they have some causes here for, in your PowerPoint, and so they have sepsis and some other things. So I'll turn this here. So they have sepsis and trauma and things like that. And then I'm going to show you another table. This table here, you don't have to memorize each and every item here, but it's just giving you some examples of things that can cause an acute respiratory distress syndrome. Honestly, anything could cause a respiratory distress syndrome. It's kind of hard to pinpoint and say, oh, well, it's just the heart, and it's just the burn injuries, and it's just cancer. Anything really could lead into this. It just depends on if it gets to that point. All right, so the pathogenesis is here, and it gets a little tricky. Well, not too tricky, it's just a little involved. So a couple of things that go on. These patients do have a widespread pulmonary inflammation that can lead to excess edema building up in the pulmonary vessels. And so this is the problem. Say for example, I'm trying to think. Say for example when we talked about shock, okay? Person has septic shock. We know septic shock, sepsis, the infection goes all over everywhere, okay, in the bloodstream. And if this inflammation continues and leads widespread in the pulmonary system, that means that that infection is taken over the pulmonary system and now most likely depleting the blood flow in the pulmonary and having issues there. Therefore leading to the respiratory distress. Another issue that can occur is something called atelectasis. Atelectasis, this term is used for when we talk about collapsing of the alveoli. So this talks about collapsing of the alveoli, atelectasis. And what is a good way that the alveoli would collapse is if you lack surfactant. Okay, and we talked about that with chapter 22. If you don't have that surfactant coating the alveoli, if it's gone, the alveoli will definitely collapse. Okay, and if the alveoli collapse, and just imagine if we have that going on in a number of different alveoli, like in a person that has emphysema, that's definitely going to lead to a respiratory distress. Okay. And the very last thing they have here is fibrosis. So how do we even get to fibrosis in the first place? Fibrosis usually develops if there's long-term type of inflammation occurring. Okay? So say you have that person that has chronic bronchitis or emphysema, and keep in mind when patients have emphysema, even just like chronic bronchitis, sometimes they don't stop smoking either, even all the way, through infant. So what happens is you keep going on, inflammation after inflammation. That at some point is going to cause extreme damage to the epithelium, okay, in the airway. And so it can lead to fibrosis. Once you have fibrosis, there's no returning back from that. And so fibrosis is a permanent thing. And so when fibrosis occurs, this will now, in the airway or anywhere in the pulmonary system, cause these patients into having a respiratory distress. So, more things about the pathogenesis. The injury to the alveoli can be from a number of disorders, like we talked about, for example, emphysema, so we already discussed that. The alveolar diameter will change, obviously, if it's collapsing. And injury to pulmonary circulation. Okay, so pulmonary circulation is offset. It will disrupt oxygen transport and utilization, and that's the key thing here, which we know. Common findings is that these patients will have severe hypoxemia. Okay, so just make sure you know that. They will have severe hypoxemia.
Oh, that's fine.
Okay.
I have an
Okay,
When we
okay, I'll come in.
Thanks.
Okay. Severe hypoxemia, so obviously if they're not getting proper blood flow and ventilation, oxygen is low. All right, so that's that. So decrease in lung compliance. Okay, again, all of this makes sense because if you don't have surfactant, if you have the alveoli collapsing, okay, and on top of that, maybe the pulmonary circulation is off. So all of that combined is obviously going to decrease lung compliance. The lung is not going to be able to expand and recoil and push and do the function that it's supposed to have proper ventilation. Okay. I'm just trying to sum this up because the pathogenesis is like a lot. Okay. So decrease in, oh wait, I don't think we need to go into this. Well, yeah, you just said, okay. FRC stands for functional residual capacity. Functional residual capacity. Functional residual capacity. So not to get into too much detail with PFTs and things like that, but say for example, if you guys remember from physiology, when you have a full exhalation, okay, you exhale, you don't exhale all the air out of your lungs, okay? There's still some air left over, which is called the residual volume. And there's part of the residual volume that's still functioning, meaning that it still has oxygen, it still has those gases there, so you can continue gas exchange even while you're exhaling. Okay, so when you exhale, everything doesn't stop for that moment. You're still having gas exchange occurring. So the problem here is that when a person is in respiratory distress, that residual capacity is not functioning the way it's supposed to. They really don't have enough oxygen to be crossing over even while they're exhaling. And gas alveolar infiltrates because of the inflammation and edema. Okay. So clinical manifestations, they will have respiratory distress, obviously sudden marked respiratory distress. So you'll see obviously a lot of labored breathing or extreme difficulty breathing. Slight increase in pulse rate. This is a compensation, obviously. Dyspnea, low partial pressure of oxygen, and shallow rapid breathing, again because of that labored breathing, and they're trying to get as much air out as they can. A late finding, so if this goes on a little longer than it should, they can have tachycardia, tachypnea, which we would imagine are compensations. Hypotension occurs because, keep in mind, pulmonary circulation is not adequate, so it's going to now offset or throw off circulation, so it'll slow it down. Restlessness, we would imagine if you have labored breathing. Crackles and rhonchi. These patients will have, when you have them breathe in and out, you'll hear those crackles and all that sound, okay, coming from the lungs. And accessory muscles, obviously, were intercostals, okay, because they're trying to breathe as best they can. And cyanosis. So the diagnosis here, they say that the hallmark is hypoxemia refractory to increased levels of supplemental oxygen. Okay, what does that mean? That means that when you give these patients supplemental oxygen as a treatment, it's a possibility that they will still fall in a respiratory distress until those oxygen levels are met, okay, to the level it needs to be. And again, I don't want to get too much detail with this because when you guys get into nursing corps, they'll go into exact detail with making sure the oxygen levels are right, and so you don't give too much and that type of thing. But this talks about that they need to bring it up to a certain level, okay? And if those O2 levels don't go up to that certain level, understand, even if you are giving them oxygen, they're still falling, okay, into that respiratory distress. So ABGs, as you would imagine, low oxygen, increased carbon dioxide, leading also into that acidosis. And PFTs, again, you don't have to worry about, you can cross that out. Chest x-ray, I don't know if I have this picture. Oh, yes, I do. Chest x-ray will show what is called a diffuse whiteout appearance. So your next picture should be this. Is this your picture? Your next picture. So you look at this x-ray and you see how it looks like someone took like an eraser with chalk and just went across the x-ray film, okay? So what you're seeing here is this whole white appearance is showing you how much destruction, okay? Well, I shouldn't say destruction, but it's showing you how much inflammation, inflammatory changes, how much changes has happened to the alveolar level in the lung tissue, okay? To the point that it just looks like a big, big mess. That's why it's white. Normally, we know it's supposed to look black, but it's white because of all the changes that's occurred in that tissue, giving that white out appearance. Okay. And so the open lung biopsy, if they do that, you can see the atelectasis, you can see the alveoli that have collapsed, you can see all of the inflammatory changes like the cellular debris, edema, all those types of things, okay, if they do a biopsy. This picture you don't have to worry about. And treatment. Treatment is more about supportive care at this point because you want to make sure these patients get the adequate amount of oxygen they need, decrease that inflammation. And the treatment is really for the underlying cause, as I told you. With a lot of conditions, you want to take care of what's the issue. Okay, you can try to manage as much as you can, but in this situation, if it's sepsis, treat the sepsis. If it's, say, a burn, treat the burn. Okay, so whatever it is, that's the underlying cause. And give them fluids and electrolytes and things to control the inflammation. Now, slide 64 and 65 goes into all the different types of oxygen that is given, okay? I don't need you to know all of that. You'll get that in a more clinical setting. But just know, obviously, oxygen needs to be given. Okay, and we looked at that whiteout appearance already. Okay, so. Okay, we're doing good on time. So we just have to do IRDS and pneumothorax, and then we're done. Okay, so IRDS, Infant Respiratory Distress Syndrome. So infants, believe it or not, can also undergo respiratory distress. Okay. In the situation with an infant, the reason why it happens with infants really doesn't have much to do with the primary condition. Most of the times it has to do with mommy. Okay, so usually the prenatal care. Okay, so maybe some sort of prenatal issues, okay, during that stage, okay, causing them to lead into this situation. Okay, so we'll get into the different types right now. Okay, so some high-risk factors are listed here. I'm not going to go over each and every one in detail, so you can just memorize this. Slide 68 and 69 are the risk factors. Yes, memorize them. So say, for example, I'll just give you a few. So say, for example, preemies, premature babies, moms that have diabetes while they're pregnant, that uncontrolled diabetes, I should say. Even moms that have hypertension that's uncontrolled while they're pregnant. What else? Moms that are at what they call advanced gestational age, so that high-risk group, like over 35, I think that's the high risk. So you get the idea. Okay, so patients that have those things. Now, if the mom has all of that going on and the baby, okay, suffers, what will happen with the baby is that the baby does not make enough surfactant, okay, because maybe they're born premature. So if they're born premature, they didn't develop enough surfactant. The lack of surfactant, we already know is going to do what? Cause the alveoli to collapse, okay, and so that's the issue. that's kind of confusing. Look, cross out 71, because that might confuse you on that. Okay. So, they will have obviously an increased burden of breathing and decreased ventilation, because if they don't have alveoli, this is going to put more strain and cause them to increase more breathing because they're starving of that oxygenated air coming in. They will have progressive atelectasis, so the alveoli will continue to collapse. They will increase in pulmonary vascular resistance, which we know if you increase pulmonary vascular resistance, this can possibly lead these infants into pulmonary hypertension. And then we know what can possibly follow after that. Hypoxemia, acidosis. Okay, so we already know the deal. Okay. They do say a secondary cause could be, you know how the capillaries sit over the alveoli? They do say that sometimes these infants can be born with not enough capillaries, okay, or immature capillaries over the alveoli. And so that will obviously cause a problem with gas exchange. So I'm just trying to sum this up because it is a lot. And they can have definitely more damage to the epithelial cells, as well as increase of capillary permeability and more leakage of fluid into the alveoli. So it'll just kind of undergo sort of an inflammatory type change, okay, which causes more issues in the alveoli. Clinical manifestations, and I'm just going to go through a few. Most of this will make sense to you, but yes, they'll have intercostal retractions because they're using all of those accessory muscles. Flaring of the nares, this I do want you to put a check mark by. How do babies breathe? Through their nose. Babies breathe through their nose because what are they doing in their mouth? They're suckling. Okay, so babies don't really know how to breathe through their mouth until they start advanced ages. Okay, well later on in life when they start to, you know, get older and eat food, and then they know how to breathe. But usually they're so busy focusing on, you know, making sure that they can, you know, feed with bottle feeding that they are breathing more so through the nose. Okay, so they don't really know how to breathe out of their mouth. So what will happen is when they're in distress, they will have flaring of the nares. So they're really trying to breathe a lot, get that air out through their nose because they don't know how to get it out through their mouth, which further complicates how they're breathing. Okay. Hypotension, bradycardia, yes, edema, yes. Okay, so some of that we know. All right, and then late finding, they can also have sputum. And frothy sputum kind of, from what I remember, looks more like milky, I shouldn't say milky, right, but it's bright. What's the cream they put on the coffee?
Creamer.
Like the hot cream when you go to Starbucks.
Oh,
The froth milk, frothy milk. Isn't that what they call it, frothy?
I know what you're saying. When
Like, you know, when you get a cappuccino and you get the steamed milk, like that.
Gotcha.
It's, yeah.
Okay.
I think they call it frothy milk. So it's kind of like that. Okay, so they also have cyanosis, yes. Grunting sound while they're trying to, you know, have that breathing. And something called paradoxical respirations. And you guys probably have seen this before, maybe on TV or in real life. When babies are in respiratory distress, you've ever seen babies where their belly kind of pops out and then the chest and it's back and forth? So this is what they call that seesaw movement because they're in such distress that that's the best way they can try to breathe. And I should say that's how you can tell they have labored breathing, okay? Usually they don't really have all of that going back and forth rapidly. So you can know that they're having issues. Okay. ABGs, as you can imagine, we already know acidosis, okay, hypoxemia, hypercapnia, okay. And the chest x-ray will show the same whiteout appearance that I showed you with ARDS. Okay, so it'll be the same thing. Now, this is another hallmark here, this slide. These patients, when the mom is pregnant, and you know how the mom has to get amniocentesis, okay? So the amniocentesis, they do a procedure where they take the needle, go in, take out some of the amniotic fluid, okay, to test it for different things. So when they take out the amniotic fluid, they are looking for this ratio, okay? Lesogen, sphingomyelin ratio, and desaturated phosphatidylcholine concentration. Okay, I know that's a lot. But the point of this material tells you how much surfactant the baby is going to make. So this material tells you how much surfactant the baby is going to make. So they can detect this from the amniocentesis. And the rest of this, you don't have to get into the percentages of ratio, but just know that that tells us how much surfactant the baby's going to make. Okay, so prevention is the primary goal. If they can, try to prevent it. If not, once the baby is born, you want to make sure that the baby has adequate oxygen levels. Okay, so you give them oxygen in whichever way you want to do it. And so we don't have to get into what types of ventilation. Okay, just know, give them oxygen. You can also give these infants exogenous surfactant. So you can actually give them surfactant that they're lacking. And they say that this really has been a good treatment to kind of help these infants get out of this situation. And here we go, ventilation again. If you need to give the ventilation for airflow, that can be given. And they do have antibiotics here because they say these babies do have more susceptibility of developing infections for some reason, okay, with this whole process. And so it is important to take care of that. And make sure you give them fluids, electrolytes, and all that. And this is the very last one. I know. And believe it or not, I actually cut this down a lot.
You did, because I went over the other one.
Yeah, because I cut out occupational lung diseases and all that. There's a whole bunch. Okay. And occupational lung diseases, it's not that complicated to understand. It's just that when people like, the 9/11 workers, they're now developing occupational lung disease. They are, what happens when it's diagnosed, unfortunately, it's too late. And so the problem is with occupational lung disease is that when the signs and symptoms don't come out until like way after exposure. And so by that time, a lot of damage has occurred. So it's kind of dormant, so to speak, for a long time. You don't know. Okay, now pneumothorax. We talked about this a little bit when I explained, what was it in class? Emphysema, okay, and the blebs and how it can burst. Okay. Now, this is accumulation of air in the pleural space. So remember that picture I drew. So air just pulls up in the pleural space, okay, for whatever reason, and so we'll go over the different types. So a primary pneumothorax is spontaneous. Okay, so this one is more spontaneous. They say can occur in men, tall and thin and all that, but no underlying disease, and they say cigarette smoking could be a possible risk. However, it's spontaneous, so I don't want you to think it's just men, tall, and the ones that are smoking, but it can be anyone. Okay, one of the instructors here actually had a spontaneous pneumothorax. Okay, it just happened. She didn't know what happened. Okay. So that's primary. Secondary pneumothorax is usually due to some sort of primary condition. Okay, and mainly the ones that we went over, like emphysema, asthma, chronic bronchitis, so those types of things. So you have them all listed here. Okay. So usually primary or secondary to some primary situation. Now, Cad Emil Pneumothorax, I always have a hard time explaining this, honestly. And I even had to ask Dr. Yusuf to continue explaining it to me because it doesn't make sense. They say it can be associated with menstruation, right? Hemothorax, associated with endometriosis. Okay, so what does this have to do with reproductive and that? So the philosophy is this. You know how sometimes females can have endometriosis and those types of conditions? These females can develop what are called like cysts. Sometimes they call them certain cysts that can develop in and around the tissue of the organs. And so if it fills up the pelvic cavity and pushes the abdominal cavity, it causes pressure in the thoracic cavity if it continues to push up. This is how it was explained to me. So the pressure in the thoracic cavity is now what causes the pneumothorax because of what's happening from below, okay? I don't know how many cases that situation occurs, but that's that. And then tension pneumothorax is when patients can have either a penetrating or non-penetrating type injury. So something that's penetrating, let's say if a person has a stab wound, okay, to the chest, or non-penetrating could be more like a crushing injury. So say if someone gets rolled over by a car, okay, that will cause, pressure in that, even though it would sound penetrating, but it's not. It's just a crushing type thing that will cause pressure in that region. And primary, we already talked about. This could be a rupture of a bleb that causes the air to spill out in the pleural cavity. Secondary, most of the times, is due to a complication of a primary condition, which also results in a rupture of a bleb. Okay. And tension pneumothorax, as I just explained, is just a bunch of air that builds up from whatever the tension is, okay, causing that issue. And okay, this is important. So, the open, as they say, sunken chest wall wound, okay, when the air enters that lung field and it builds up, builds up, builds up, understand that that air is going to push on the mediastinum. So everything that's in the mediastinum, the heart, the trachea, is going to shift, okay? So they have this as a shift in the mediastinum. So let me go to the picture. We have it here. So you have this picture in your picture sheet, okay? And so you see this? That looks scary, okay? This is the heart. The heart's way over here. The heart's supposed to be here. So what you're looking at is that this patient has the pneumothorax here on this side. All of that air pushing up, building up the pressure, is putting pressure on the mediastinum, making the heart push over to the contralateral side. Okay, so that's the issue. Okay, and so they're trying to show you even there with that diagram. And they have that in your book, you can look at that at home. And so clinical manifestations, they will have small pneumothoraces, so they will have small areas of where they'll have a little area buildup. Tachycardia, decrease or absent breath sounds on the affected side, obviously, because if it's full of air, there's nothing in there, and so they won't have breath sounds. Hyperresonance. You've ever seen, in probably where you work, when you listen to the lungs and you have breathing in and out, but then they also do something where they tap, okay, on the lung fields. You're actually looking for just, just a little sound. It's going to sound hollow because nothing should be in there. However, it's going to be hyperresonant, so it's going to sound louder, okay, like a drum, a loud drum. The reason why is because that air is too much air there, okay, so it'll sound louder. And chest pain, obviously, on the affected side where they have the pneumothorax, okay, and dyspnea. And tension and large spontaneous pneumothorax are definitely emergency situations. Well, I would imagine any pneumothorax would be an emergency situation. But these more severe ones have severe tachycardia, hypotension, that shift, okay, of the heart and the trachea, and neck vein distension, okay, hyperresonance, and then something called subcutaneous emphysema. Now, you don't have this picture, you don't have to worry, but I just want to show you. You see this gentleman, you see his face and his eye and how it's all swollen. That looks like fluid, correct? Well, it's not. That's actually air. So what happens with subcutaneous emphysema, the air that's in the pleural cavity, if it keeps building up, building up, building up, where do you think this air is going to go? The lungs already collapsed, okay? Is pushing out the mediastinum. It has nowhere else to go but into the tissues. So the air is going to seep into the subcutaneous tissues. And the patients will have air under the skin, in the tissues under the skin. And I've never touched this before, but people say it feels like rice or sounds like Rice Krispies because the skin is like really hard and crackly because that's air underneath. Okay, and so I'm sure you'll touch it next term. Okay, all right. So ABGs, okay, we would imagine what it is there. And I'm sorry, this is a typo. Respiratory acidosis. There's too many typos here. Respiratory acidosis, not alkalosis. And chest x-ray is pretty much going to show all of the things, showing the tracheal shift and the heart moving to the side and all that. And there it is. Okay, so that's what the chest x-ray looks like. Okay. There will be an ECG that should be performed, obviously, because the heart is displaced. So you would definitely want to check the ECG. You don't have to memorize the changes, but just know an ECG should be done. And treatment. Treatment depends on the severity. Now, they have listed here in slides, what is this? Slide 95 and 96, different ways of treating it. And in 95, they say, okay, well, if the person has less than 15% lung collapse or whatever. So my knowledge, when a person has a pneumothorax, is, from what I hear, a chest tube is inserted to make sure you get that air out. Okay, so I don't know how much of a percentage of a collapse. So you guys will get more detail with that in clinicals, but you definitely want to get that air out. Okay.
But we don't have to know the 15%.
No, you don't have to know the 15%. You don't have to memorize that. But I just want you to know, obviously, it has to leave somehow. Now, then they have some other procedures where they can actually try to go in and prevent the blebs from bursting, okay? And try to prevent the rupturing from happening in the lung. So they have different procedures for that. Most likely, I'm not going to test you on this, but I just want you to know they have other procedures for that. And then that's it. Is that the last slide?
Yep.
Okay. We're done with 23. I know. That's a lot.